Welcome to Your Doctor Wants to Quit, a podcast inspired by the need to save healthcare in America. I am Dr. Joy, a board-certified emergency physician, and I created this podcast to shed light on the challenges our healthcare system is facing through the multiple lenses of doctors, other healthcare professionals, and patients. By listening and working together, I believe we can fix healthcare in America for all of us.
There's tons of doctors out there and health practitioners of different kinds, and it is difficult for the general public to tell which one is giving you accurate information and which one is just saying nonsense to get popular online. You've got one cardiologist saying cholesterol will accelerate your death rates by heart disease, and someone else who looks legitimate, he's popular, he goes on Joe Rogan, he goes on Huberman and all these other podcasts, and he's saying the opposite. So really, like, if you're a normal person, who do you trust? How do you know what to follow, or who do you talk to, or how you understand these things? It's not easy. I totally get it. It's frustrating, I'm sure.
That's the voice of Dr. Mo Allo, a board-certified practicing cardiologist who has been working overtime not only to take care of his patients, but also to grow his presence online in a quest to combat the tsunami of misleading and false medical information that has inundated social media channels.
For the last several years, I've been debunking online misinformation. I noticed there was a huge lack of real information from real physicians. You just had the online and social media space dominated by these non-physician medfluencers and healthfluencers that just want to sell you products and affiliate links and supplements and all kinds of nonsense, telling people that you should eat diets and consume foods that actually raise your cholesterol and cause more heart disease and more hypertension. So I wanted to make sure people are getting correct information. And it's been a long battle. It seems like every day people send me more videos to debunk. And it's a lot of the same themes over and over again, that people should be consuming more red meat and more butter, and you shouldn't worry about blood pressure and cholesterol. And if you just ate right and ran around more, you'd get rid of your diabetes and hypertension and cholesterol problems, which definitely can help, but not in all cases. So debunking a lot of this and bringing real accurate information to the masses, I think, is super important. So I've been trying to do that as much as possible. It's an uphill battle, but I'm trying my best. I'm getting about 8.9 million views a month now across all platforms. I'm hoping the information gets out there so that people learn how to live longer, healthier, happier lives in today's modern world with modern therapeutics, modern treatments, and hopefully they don't end up being my patients.
Dr. Allo grew up in Toledo, Ohio, and he knew at a young age that he wanted to become a doctor like his father, who was a surgeon. Despite his aspirations to become a physician, Dr. Allo didn't always have his sights set on becoming a medical communicator with an online presence that now reaches over 9 million people each month. He did, however, have other passions that have informed his career in unexpected ways.
I'm based in Toledo, Ohio. I went to school at St. John's High School, attended University of Toledo, did an economics and finance degree, and then I moved to Chicago for medical school. I worked in all different kinds of businesses prior to that. But my passion is sports, and even till today I coach sports. I've coached almost every sport you can imagine, but the one I like coaching the most is football. So I used to run a website, and I still run it, called Football Times. And in the late 90s, kind of when the internet and websites took off, it was like a hub for football coaches. And football coaches would come on there. It was like an online forum. They kind of don't exist anymore, but imagine like Reddit, but it's hosted on like an actual website. You go to footballtimes.org, like organization, and you go to the forums and you sign up, you get an account, you share playbooks and offensive strategies, defensive strategies, all kinds of things. There's tons of articles on there. It's like, people upload plays and discuss how to best use them and not use them, different kinds of injuries, how to eat right for football games, how to coach youth football, whether it's tackle or flag or whatever it is. I've been doing it for 18 years now. Sometimes I'm walking around in the grocery store and this huge adult will come up to me and be like, "Hey, Coach Allo, what's up?" And I'm like, "Mark, damn, you're like 6'7" now." And I remember when he was like 10 years old. No, but it's super cool. But yeah, being a football coach and a mentor to young people and giving back, I enjoy that aspect of it, where the kids are active and doing activities that they enjoy and love. I never dissuade people from doing any activity that they love and enjoy. And I tell a lot of my patients, pick the activity you enjoy the most and just do it. That's the Dr. Allo that probably nobody knows. I'm the Coach Allo. I've always wanted to be a doctor. My dad was a doctor. He worked really hard. He took care of patients. People loved him. And it was always something I looked up to. I said, you know what, that's a super cool field. That's what I want to do. He wanted me to be a surgeon like him, which I tried to be. I did trauma surgery and gynecological surgery and plastic surgery. I did all these rotations in surgery. Plastics was definitely my favorite, like stitching up little kids' faces and trying to eliminate scars as much as possible. That I really enjoyed. Trauma surgery was really fun too, because you never know what you're going to walk into. But I'd applied to all these general surgery residencies, and then my last rotation ever was cardiology. And I had this mentor, his name was Dr. Ali. He passed away recently. He was only 51. He passed away from left-sided colon cancer, which is super rare, but it's because he was in the cath lab all day. The left side of your body gets radiated nonstop because that's where the camera is. Even though you're wearing lead and protected, and got caught late, and he battled with it for 3 years. He got it at age 48 and never made it, obviously. But he was super charismatic, loved cardiology. He was always talking about studies, taking us to the cath lab, showing us echoes, showing us the procedures that were done, and we loved it. And I loved it. And I was like, you know what? This is something I can definitely do. It combines a lot of sports medicine, sports that I enjoy, like being healthy, nutrition. I was always into weight loss, nutrition / lifestyle / medicine. And I really enjoyed it. I thought it was like a perfect fit for me. And I'm a certified personal trainer too. So to me, it was a combination of all those things together, where you're combining exercise, nutrition, living a healthy lifestyle, curing heart disease, preventing heart disease, treating heart disease, into one single field that lets you do all of these things. So I really enjoyed it.
So that's kind of interesting to me, because if I think about the presence that you've built online and the message that you have, it's about debunking these med influencers, as you say. A lot of them do come from the nutrition space. They come from the perspective of personal training, eating healthy, all those kinds of things. And I think there's a perception in the public that physicians are just pushing pills, that all we care about is people taking pharmaceuticals. But what I'm hearing you talk about is a lot about lifestyle.
Yeah, 90% of what we do, and this is the thing I don't think people understand online, 90% of what we do is tell people to eat right, exercise. And the problem is, even if you did all of that, and that's part of my cholesterol book. There was the history of cholesterol and how we discovered heart disease and whatnot. They've done CT scans and all these, fancy studies on mummies, and they found that they all had atherosclerosis, even though they're like 35, 40, 42 years old was like the average age of death at the time. This is like 6,000 years ago, whatever mummies are. And they found that they were all dead by like 42 at the most, and they all had atherosclerosis. So even if you did all the quote unquote healthy lifestyle, exercise, all of that, you and I know that you see patients every day that are super fit and healthy, but they have heart failure, they've had a stroke, they have insanely high cholesterol, high blood pressure, all these silent killers that you can't see them, you can't feel them. Like patients come in with a blood pressure of 220, you've seen them in the ER. The only reason they know it's 220 is because they checked. Like they feel fine. And they come in with a blood sugar of 600 and they feel fine, just a little off, right? And so these things are all silent killers, where if we didn't have modern medicine and therapeutics, a lot of these people wouldn't live as long as they do now. We've doubled lifespans since just even 1900 or even the 1940s, and people don't realize that. So the nutrition space and these health influencers, they're nutritionists or certified personal trainers, and sometimes even doctors, chiropractors, people with advanced degrees too. They come online and they want to make it sound like, well, if you just ate right and exercised every day and did my program, took my supplements, you would live to 100, which we've already done that experiment, and it's not true. You might, if you have perfect genetics and your cholesterol is super low and you never have a blood pressure or diabetes problem, absolutely. If you do all the right things, you are increasing your chance of living a long and healthy life. However, the vast majority of people don't fall into that category. Like, what percentage of people live to 100 without anything? Like, if you go back in time into even the 1600s, 1700s, not that many people live to 100. When you lived to 60, it was considered great. Like, you lived a long life. And a lot of my patients now today are like, Doc, I've made it to 65. I've lived a good life. I don't want anything done. We're like, dude, it's just a heart cath. Like, you're not going to die. Like, we just need to look at your arteries from the inside. And they think like, no, Doc, it's okay. I've lived a good life. Like, dude, you're 63. Like, you could be a 93. It's pretty easy these days. So I think debunking these things is very important, because these people make it sound like, if you just did all the right things, you would somehow live to as long as you possibly could, which is obviously not true. And they perpetuate these things, but they also perpetuate a distrust of doctors, which I don't think is accurate. They want to say, like, don't follow Western medicine, and Western medicine wants to keep you sick, and they profit off of your not being healthy and all that, which our health system isn't perfect. I'm sure, you talk about this all the time, and so do I. It's not a perfect system, and there's probably some of that, Sure, the health industry in general does probably make more money because people are unhealthy, but they're not trying to promote you being unhealthy or like paying and making laws and creating a place where people get unhealthy and they have to be a part of the system so that some rich CEO of somewhere is making billions while the rest of people are dying. I don't think anybody goes in with those intentions at all. At least doctors don't have that intention. We see patients, we get them better. How many miracles have you seen, obviously in the ER or in primary care, you work in primary care now. I mean, you see people that come in, they were 300 pounds, they've lost 170, now they're 130, they're living their best life. They did all the healthy lifestyle, cutting calorie, eating right, all of that. But now with modern medications, it's so much easier to stick to a calorie deficit. I mean, part of my practice is obesity medicine. Now with medications, we're able to make the lifestyle changes a lot easier. And in fact, the placebo arm in most of these studies where they studied Ozempic and Mounjaro and all of these other ones, even Byetta and Victoza and Trulicity, all the GLP-1s, the placebo arm was diet and exercise. And you met with a nutritionist every week and a physical therapist or a certified personal trainer every week. And you exercised like crazy and you ate the right things and you were in a calorie deficit, and they lost like 2 to 5% of their body weight. You add a GLP-1 to that, so they're still doing the diet and exercise. You add a GLP-1 and now they're losing 22 to 26% of their body weight, which is insane. And that's just those. When you add other medications to that, because in obesity medicine you don't just start somebody on one single medication, but the studies are to prove that this one medication works. But when you add other things like metformin or naltrexone or bupropion, there's a lot of other options, like 10 or 12 different things. But you start somebody on a combination of 2 or 3 different things, now they're losing 40% of their body weight, 35%. We're beating gastric bypass in obesity medicine. It's remarkable. I had a guy that came to see me. He's 470 pounds at least, and he needed clearance. He needed cardiac clearance for gastric bypass. So naturally I asked him, when's your surgery? We'll get you cleared before surgery. I'm thinking like it's in a week or two and in a month or two, how they usually are. He's like, oh, it's going to be in a couple years. I'm like, what do you mean it's going to be in a couple years? Like, why are you here today then? He's like, well, I got to get under 400 pounds before they'll do the surgery. I was like, oh, I got you. He's 215 now. It's like 7-8 months later. He's 215, and I was like, okay, we can clear you for surgery. And I was like, doc, why can't I just keep doing this? I'm like, you can? So now he's like 190. This is like a year and a half later, maybe. And he was 470. He's like now able to walk and exercise. He's motivated about eating healthy. He's not doing what he used to do. Like, you can't do a whole lot of exercise when you're 473 pounds. Like, even getting up to use the bathroom is a struggle. So he wasn't even able to do that. He's like, doc, what do you mean exercise? I can't even go to the bathroom. Like, I can't breathe when I stand up.
Poor guy.
Right. I mean, this is common. I'm sure you see these patients. They're extremely overweight. Even just standing up, they're out of breath. They can't do what they want to do. And all the lifestyle interventions in the world might lose a few pounds. I mean, that's what we've done in the past. It's really difficult to lose weight with just lifestyle. People have done it, don't get me wrong, but 70% of Americans have lost significant weight. No question, like 2/3 of the country. The problem is almost 95% gain it all back. So it's not like losing weight is not the hard part. You can just starve yourself. That's not hard. But then staying that way or finding a sustainable plan or diet or something is not easy. Everyone gains the weight back, and that's the actual problem. So, a huge part of my practice as a preventive cardiologist, not just dealing with cholesterol. People think that I'm just pushing pills because like every one of my videos is about some medicine or whatever. Sure, because like who else is going to talk about medications? Any fitness trainer can talk about diet and exercise, and but nobody knows the intricacies of which statin to pick and which one lasts the longest and which one has the least side effects, which one has the least interactions. There's a vacuum out there, and that kind of information you can't really get from anyone else. Your 20-year-old certified personal trainer is really good at training you. Your nutritionist knows a lot about nutrition, but they can't sit there and tell you the intricacies of statin medications. And a pharmacist, I'm married to a pharmacist. They know a lot about medications, but they don't really know like which one do you start and like how does it actually work. Like, I can almost predict to within 3 points if I put you on Crestor 20 what your LDL is going to be in a few days. I mean, that's how good you get when you deal with these medications every day. So we are experts in dealing with these kind of things. So people need that kind of information online too. Everybody gets sick eventually and needs physicians. But what we're trying to do in the primary or preventative world, like what both of us do now, is to try to prevent these things as much as possible so that you don't need healthcare, and it's mostly preventative. And sometimes some things are not preventable. And if you need somebody, you know where to go and what to ask and kind of what the treatment plan should be or shouldn't be. and it's not, like when you're too far gone. The problem with me as a cardiologist, I see patients after they've had a stroke, after they've had a heart attack, after they've had quadruple bypass, after they've had chest pain. So for me, like I catch patients at the end of their healthcare journey. People in primary care, like your family doctor, NP, or whoever it is, they catch you in the beginning, hopefully trying to prevent you to ending up with me. But it doesn't always work out. Some things are super genetic and difficult to fix and control, and you ultimately need an expert in whatever field of, cancer, endocrinology, whatever you have, cardiologist. So I'm trying to make basic cardiology and preventive medicine accessible to the world. Myself and Dr. Thomas Dayspring, the world's greatest lipidologist, wrote a cholesterol book it's mainly about preventing heart disease. Like it's 520 pages. 6 of those pages are about the medications that you can use to lower cholesterol. The other 510 pages are what to eat and what not to eat. Like 800 different studies showing you how to live and how not to live, and the history of cholesterol, how it started, how we discovered it, how we know it actually causes heart disease. So that is all. Out of the 516 pages, literally only 6 talk about statins, PCSK9s, bempedoic acid, whatever. The few handful of meds that we have to lower cholesterol. The rest is all about basically how to eat and what not to eat and how to live your life. So people say, you just push statins. Well, I do, because they save lives. They add decades to your life. But what we push is a whole program, hopefully before you get to that point. And I think people don't see it, or they discount it, or they just say, you guys are just here pushing meds and pills and whatever. That's not what we're trying to do, but a lot of times people unfortunately end up needing them, and they need some information about that too.
Statins are just one tool in your toolbox, but there's a lot of tools, and we use the tool that's appropriate for the job. A lot of people that are online are really just trying to sell supplements. I mean, talk about perverse incentives, right? Everybody wants to say doctors are getting paid by pharmaceutical companies, which we're not, by the way.
I mean, you can look it up online. It's free. I actually have a link to my open payments profile. You can click on my website everywhere. It says disclosures and conflicts of interest. You can go read it and click on the link. Most of these meds are generic. Like nobody's paying you to prescribe a generic medication that's been around for 30 years. And then, they say we're profiting off of big pharma, big supplement, if it's what you want to call them. The wellness industry in the United States is $6 trillion. Like people say, well, you guys are just doing this, but big wellness, if you want to call it that, is bigger. They're selling you supplements and saunas and red lights and stretchy things that you do every morning and mats to lay on because they're electromagnetically neutral, and some water stirring wands that are magical, and hydrogenators for water, like as if water isn't made of hydrogen, and all this nonsense that is more lucrative. I mean, if I wanted right now with 9 million views a month to sell supplements, I could retire and probably live on a yacht for the rest of my life, because it would be just so lucrative. But it's unethical. All of the medications in cardiology, at least, started from some natural supplement. Like the biggest one is aspirin. It's oil of wintergreen. It comes from the willow bark, the bark of a willow tree. People, when they'd have a toothache or a stomach ache, they'd give them a piece of bark to put in their mouth, go sit in a corner, you absorb salicylic acid, and your pain goes away. And Coumadin is from sweet clover. It's one of the most popular blood thinners. Statins come from yeast. GLP-1s, like Ozempic. I don't know, you guys are close to Arizona. It was from the saliva of a lizard in Arizona, the only venomous lizard in the United States, called the Gila monster. It's pronounced Gila. They found a molecule in its saliva that was Byetta, the very first exenatide, the very first GLP-1. And the guy was trying to sell it to Big Pharma. He discovered it in the 1980s. He's trying to sell it to Big Pharma, like the patent to it, for like 2 decades. Finally, in 97 or something, Emelin, which went bankrupt eventually, bought it. And then like in 2005, it became Byetta. It was the first time. It's 2005. It's literally like 25 years of testing and whatever. People just see a new drug and they're like, this was never tested. It's like, it's been tested for 25 years before it finally made it to market. And this is common. Like every medication, it's usually being studied for 10 to 15 years, and like 90% of them get tossed out because they just don't work, or they had some weird reactions and too many adverse effects or whatever. So by the time something gets to market, it's pretty well proven, well tolerated, minimal to no side effects. But metformin is like the French lilac flower. Digoxin comes from the foxglove leaves. People used to eat foxglove leaves in their salad, and they'd end up with like a heart block and tired and fatigued and won't wake up. That's how they discovered it. So there's so many. And then lisinopril is viper venom. Like all of these medications come from a supplement somewhere. Some person discovered it. There's been several medications like Multac. Multac is amiodarone minus the iodine. They tried to sell this Multec drug to cardiologists, and it was the next billion-dollar drug. It was great. It was amiodarone without the iodine, no side effects, no weird, stuff. But it turns out it doesn't work. Like it didn't really work. So no one really prescribed it, and it eventually is now $3,000 a month. No insurance will pay for it because it doesn't do anything. So we're not dumb. Like if something doesn't work, we're not going to use it. We're not going to be like, well, they're paying me $50,000 a year. Well, first of all, they don't. But nobody would use something that's not efficacious. But the supplement salespeople will. I know several influencers because I have a friend that does some of their public relations. They know that this thing that they're selling doesn't do anything and possibly causes harm, but they make $150,000 a month from it, and it's in their best interest to talk about it all the time. So I think you need to find ethical people to follow that tell the truth and have nothing to gain or lose.
Do you think that there is a way to do integrative medicine the right way?
What is your definition of integrative medicine?
My definition of integrative medicine would mean that you're collaborating between holistic providers and conventional providers to bring more tools to bear to support patients.
So I think every patient should see a nutritionist and a personal trainer. I think that would be logical. But what do you mean by holistic providers? Like what is that?
Well, maybe a good example would be acupuncture.
People go to it, but I'm not going to recommend it if like I'm not going to dissuade them. Like a lot of my patients are like, yeah, I was at the chiropractor, my back hurt and it feels better now. Okay, great. But the problem is when you have chiropractors calling themselves doctors on Instagram and whatever, TikTok, saying, I'm Dr. So-and-so. And did your doctor ever tell you that cholesterol is bad for you? Well, blah, 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 blah. This study. And then they use like our studies to sell whatever the nonsense is they're selling. So I think that's unethical. Like you could be a chiropractor and do your thing. Just stay in your lane, and you should identify what kind of doctor you are. Are you a medical doctor? Are you a DO? Are you a doctor of nurse practitioner? Are you a doctor of physical therapy? Even there's a doctor of physical therapy now. There's a doctor of pharmacy, a doctor of jurisprudence, a doctor in economics. Like all of my professors in college were Dr. So-and-so, but they're economists. Like that's their job. They don't come up and say, let's talk about blood pressure today. Like that would be insane.
Well, and even within the house of medicine, somebody who's a cardiologist isn't going to operate on a gallbladder, for example. I mean, we all have our different areas of expertise and training and all of that. So it is important, I think, like as a patient, as a consumer, if you're looking to seek services from someone that you understand what their training background is before you proceed with whatever they're recommending so that you can verify that they really know what they're doing.
Yeah, and a lot of times people ask me questions on some of my videos. They're like, Doc, I got this blue thing growing on my right toe. I'm like, sorry, that is not my field of expertise. You should probably see a dermatologist or podiatrist. So I think if you set limits and you know your own limitations, that's a really good thing. People ask me all kinds of weird questions. Once they see the word doctor online, they think you know everything. They think you're like a Botox injector sometimes, you're a eye doctor. They're like, Doc, they sent me a picture of their eye with a little thing, and I'm like, dude, a heart is over here. That is not related. So I think like it's an ethical person would say, listen, I'm not really sure what that is. That's not my specialty. Even if I know something about it, I don't know the latest information. Like I know what a migraine is. I know what a broken knee is. I've torn ACLs. I know what an ACL tear is. I've torn a rotator cuff. I know what that is. I know what they're going to do. But if somebody asks me, Doc, I think I tore my ACL. What do you think I should do? Even though I know more than the general public about it because I'm actually a doctor and I'm a patient of a torn ACL, I'm still not going to say, well, you might need this and an MRI. Like, I don't know the latest data on it. That was 7 years ago. Like, I'm not an ACL expert. You should talk to an orthopedic surgeon that does 15 of them a day. They would know way more than me.
I guess that's kind of where my question was coming from, which is that at least what I believe is that there is a place for integrative medicine. The problem is you have a lot of providers of different kinds that are going online and they're not staying in their lane and they're giving advice on things that are not in their wheelhouse. But it doesn't mean that your acupuncturist isn't potentially helpful to you in certain situations. Like if you have issues with sleep or you have issues with headaches, there are some modalities that can be helpful, for those kinds of things. But also the other aspect of this is we have to think about the acuity of the condition or the severity of the condition. If you have tension headaches and you go see an acupuncturist to try to get treatment and it works or it doesn't work, your life is not in the balance per se. If you're seeking advice from somebody about cardiovascular disease who's not an expert in that, your life could be in the balance if you make the wrong choice. And so I think that's also how, at least for me, I draw the line in the sand, which is when this is something that could be life-threatening, that could take your life, you really need to make sure you're getting the right advice, and you don't have time. You can't take the risk of trying different things that may or may not work.
No, I totally agree. And people think that I'm anti-chiropractor because I do a lot of videos. People send me videos of chiropractors talking about cholesterol all the time. So I do a lot of videos. So people think I hate chiropractors. I don't. My best friend that I golf with is a chiropractor. And I don't care if you do chiropractic or acupuncture or hypnosis or massage therapy or whatever. You can go do all those things. Go see whoever you want. I'm not against them. But like you said, if they don't stay within their boundaries, that's when it becomes problematic. So I think if everyone stays within their expertise and doesn't encroach on everyone else's scope of practice, I think then we would be fine. I wouldn't care if you do chiropractic or acupuncture or whatever. I don't mind at all.
So, one thing that I think we should talk about is the difference in terms of patient case experience that physicians have based on their training versus someone that's even a nutritionist or a personal trainer, chiropractor, naturopathic doctor, any of those professionals that we would love to work with when it comes to doing things in an evidence based manner and making sure that we're all doing the thing that we're trained to do. But doctors have a little bit of a different experience because of the way that our training is structured and the types of cases that we see. And I think that's something that maybe is not fully appreciated by the general public, just the volume of acute cases that we see during our training, which obviously that impacts how we view what our treatment plans should be, because we want to prevent patients from getting to that point of showing up in the hospital without a heartbeat, showing up in the hospital with a heart attack or a stroke. Your training, your background, and what you've seen in the ICU, what you've seen in the emergency department, that informs how you practice when you're in clinic.
So the worst case scenario is when a 28-year-old comes in full cardiac arrest and you have to put them on ECMO or take them to the cath lab, open up an artery, or go for open heart surgery urgently. We're tainted as physicians by the worst case scenarios. Like as a cardiologist especially, we see the worst of the worst. And in residency, in our training, and currently, like my entire ICU, these are post-open heart surgery, sometimes people on ECMO, which is like almost like a dialysis machine that oxygenates your blood for you because your lungs aren't working very well. We have people on balloons and impellas and fancy stuff just to keep them barely alive so that they can maybe live to see tomorrow, and their families all sitting there. And a lot of times, you can ask other cardiologists, we round on patients to round on their families because like the patient's brain dead almost, or like getting there, and they're on all these tubes and devices flying out of them, which to us looks normal, but the family's like, what is going on here? And you go round just to round on the patient's family, like, hey, how's he doing? Well, it's not looking good, We're waiting to see if neurology thinks there's any brain function. And I'm sure as an ER doctor, they walk through your door, before they even get to us, and you see the nightmare scenarios, and people don't understand that they just see like, well, yeah, my blood pressure's a little high, or my cholesterol is borderline.
Right. And then what's going through our minds is flashbacks to all of these horrific cases, tragic things that have happened that we've seen, try to reverse something when it was almost too late. Sometimes we're successful and sometimes we're not. And the last thing I want is for the person that's coming to me that trusts me to try to prevent some of these things from happening to end up in that situation. And so sometimes when we're not in alignment and it feels like there's tension and I'm saying, you know what, I really think we need to treat your blood pressure. We really need to get it down. And the patient's telling me, I feel fine. I'm like, well,
you feel fine until something horrific happens.
Right. And I would never want that to be the case because I didn't advocate enough for the things that we can do on the prevention side. And I think when you don't have that perspective because you haven't worked in the ICU. So when I did my emergency medicine residency, I worked at a level 1 trauma center. I did 6 months of ICU. We also took care of a lot of really underserved patients that didn't have access to primary care. And so they had a lot of untreated chronic health conditions, and they would come in with all kinds of issues, diabetic ketoacidosis, aortic dissection, aneurysm rupture, myocardial infarction, all of these things. And I'm the one that has to not only stabilize the patient, but, also, like you said, talk to the family, a lot of times giving bad news. It's awful to see the impact of these chronic conditions on people's lives and how it impacts them, but also the people that love them and care for them. And so I think it's underappreciated sometimes in that conversation, because I'm not going to say to my patient, oh, well, here's all the crazy, horrible things that could happen. I don't want to scare people or use a scare tactic, but it's also always in the back of my mind. I don't want this person that's sitting in front of me that I care about so much, who's coming to me and trusting me for advice, to ever end up in a situation like that.
And I think it's hard to convey the gravity of the situation all the time. Like a patient's like, I feel fine, doc. Like, what do you mean? Okay, my LDL is 142. I'm great. I feel amazing. I'm working out every day. I eat meat all the time. I feel amazing. And then it's like, yeah, but your arteries, like you're going to end up, coming in as one of these cardiac arrests where they first come to you, then they come to me, and like we're trying to salvage what we can. Maybe they're brain dead at this point. But again, like people don't see that, and they don't see that often, and so they think it doesn't exist. Like their perception is different. They think like, oh, it's just a little high blood pressure, big deal. But they don't see the worst of the worst. And like when we go around in the hospital and some of our critical cardiac ICU, it's like, holy crap, this is like crazy. It's like you're walking through like a death ward sometimes. Like everybody's on a ventilator, everybody's on ECMO, everybody's on the world's worst things you can imagine. And it's like, this sucks.
It's heartbreaking.
Yeah, absolutely. It's the hardest part of medicine, especially when it's like a 28-year-old who just gave birth and the dad's sitting there holding the 2-week-old newborn, and you're like, wow, what do we tell them? It's like the worst thing you can imagine. But, it is what it is. Unfortunately, people don't see that.
Yeah, and I think people going online and saying cholesterol doesn't matter. I mean, these people that may have some type of a medical background or an integrative background or wellness background, they aren't the ones that have been in the ICU. They aren't the ones that have been in the emergency department on the receiving end of these horrific cases. Even if some of them may be well-intentioned, they want people to live a healthy lifestyle, they may not understand the full gravity of what some of these chronic silent killers can actually do to people. And so I think that they don't see it through the same lens. And not to discount diet, nutrition, all those things are important, but we really have to take it seriously when it comes to the data points like LDL. There's examples of this in other fields, not just cardiology. There are certain things that we really cannot circumvent treating because it's too risky. And diet and lifestyle is not necessarily going to be appropriate in every single situation. It's always a good adjunct.
Yeah, and like I said, like people come to cardiologists after the fact. Like people don't come to me when they're like 15, like, doc, I don't want to ever see you when I'm 40. Like that would be great. But they don't. They come to me after they've had a heart attack, after they've been in the ICU, after they've had open heart surgery. They come to me when it's like, I've had 3 strokes and like, my heart barely pumps. I'm on a pump just to pump my heart. We see people more towards the more advanced, worst case scenarios. And the people online, like you said, these wellness influencers, they don't see that at all. They don't know. They see healthy people. Like people come in like, what should I eat? Like, as a healthy person coming in saying that. I mean, of course, you could eat almost anything at that point and be fine. But when it accumulates, it's a lifelong exposure to high LDL or blood pressure or sugar or whatever it is. Over time, all that stuff catches up with you, and then unfortunately sometimes you end up with cardiac arrest, and we can't bring you back all the time. I mean, luckily we can most of the time, but not always. A lot of times there'll be a comment somebody put online like, doc, this other cardiologist said the opposite of what you say. How do we know who to trust? It is hard. I mean, there's tons of doctors out there and health practitioners of different kinds, and it is difficult for the general public to tell which one is giving you accurate information and which one is just saying nonsense to get popular online. Like there's this one cardiologist who goes on all the major podcasts and tells people not to worry about cholesterol and never take statins because it only adds 3 days to your life, which the authors of that study retracted. But of course, he doesn't bother telling them that. And there was another study where it said the longest living people had the highest cholesterols. The authors of that study also retracted that. They said, no, the data never said that, but people are saying it. So like, who do you trust? You've got one cardiologist saying cholesterol will accelerate your death rates by heart disease, and someone else who looks legitimate, he's popular, he goes on Joe Rogan, he goes on Huberman and all these other podcasts, and he's saying the opposite. So really, like if you're a normal person, who do you trust? Like, how do you know what to follow, or who do you talk to, or how you understand these things? It's not easy. I totally get it. It's frustrating, I'm sure.
What it makes me think about actually is this concept of level of evidence. In medical school, most of us actually take classes to understand how to evaluate clinical trials and how to tell when you're reading a clinical study, not just interpreting the conclusions and ingesting that information, but actually looking at how the study was conducted, how it was designed, to evaluate objectively if the study was powered correctly, if they're disclosing their methods, so you're able to think independently about, okay, could there be confounding factors here that could have affected the outcome of this study, and how reliable is this data? So we actually take classes to be able to do that kind of interpretation of medical research, which is critical for ongoing learning, right? Because you graduate from medical school, you finish residency, it's not like your education stops there. Part of what our responsibility to society is to continue staying up to date on research and educating ourselves as time goes on. And as you mentioned, there's a lot of studies that get published, and then sometimes they reevaluate the data and it gets retracted. And it's a very dynamic thing that is evolving continuously. And then new studies come out that show maybe something different than what we thought. And so I think sometimes even for trained professionals, it's hard because it can be dynamic, but it's that critical thinking and understanding how to evaluate evidence that I think is part of what our responsibility is to our patients and to society. And I think people think, oh, there was this random study that was, published, and, the subject group only had 5 or 10 patients in it.
Versus a study of 54 million person
Right.
years of follow-up.
Right. And for whatever reason, those two studies kind of get held side by side for comparison, when really you can't even come close to comparing those studies. It's like apples and oranges, right? Not all research is created equal, is what I'm trying to say. And just because a random person did a study and publishes those results online doesn't make whatever they're saying necessarily legitimate, even if there is research to back it up. And that can be really hard. I mean, it's hard for medical students to learn that skill set. Never mind the general public that doesn't have a background in statistics, doesn't have a background in biochemistry. It's one of those skills that we cultivate over time.
And to that point, a lot of times people will publish studies, they're called, state-of-the-art review. And people think that's an actual study. It's not. It's someone's opinion. It's an opinion piece. People will be like, well, doc, you keep saying saturated fat is bad for you. What about this study? And then they'll post like a link to a Journal of the American College of Cardiology state-of-the-art review. And then you go read it. And these are just like opinions. Somebody cherry picks a couple of studies, talk a little bit about the history of saturated fat, and then they find like 1 or 2 studies, and therefore, and they come up with a predetermined conclusion that supports their, original thesis. Those are not actual studies. There's a guy who keeps publishing these state-of-the-art reviews. Every 4 or 5 years, he puts one out that is basically the same thing as the other one. And then when you argue with him online, he's like, well, yeah, here's my evidence. And he posts a link to his own study, to his own source. I'm like, dude, you just cited your own opinion piece. That's not a study. Like, how about like a randomized control trial? He publishes an opinion piece so he can later cite it in his online arguments. And then to your point, one of the chapters in my book is called That One Study. So like a lot of people be like, what about that one study? And literally it's one study of like 5 mice. And you're trying to say 9 billion people on Earth should go by what this one study showed on 9 mice. Like, that's insane. But yeah, the level of evidence, the quality of evidence, the reproducibility of evidence. Like if she publishes a study that shows that drinking green apple juice will grow horns and publishes her methods and whatever, and then I reproduce it and it doesn't work, then her study was nonsense. Like, your study needs to be reproducible. That's why you publish your methods. After several different labs and professors have done it and shown the same results, then we consider it real evidence. But like if one person publishes one study with some bizarre thing that contradicts 120 years of evidence on cholesterol, no one is going to listen to that. I mean, that's just insane. Like, we have 120 years of research on cholesterol now showing that LDL cholesterol is the causative agent of atherosclerosis. If she publishes a study tomorrow where she did it and it didn't seem to match what we've known for 120 years, no one will even flinch. Like, no one in the world of cardiology can be like, oh, maybe we should reevaluate this. It's not going to happen. It's just not how it works. There's this one guy who does just that. He publishes random nonsense. So we're like, well, come to the College of Cardiology conference, come present your evidence. Let's see how fast you get laughed out of the room. Present your study, present your opinion piece, see how fast they pick you apart. If you are going to refute 120 years of evidence on a certain topic, then your evidence needs to be really, really good. Like, it can't be like, I just read a couple things and wrote up an opinion piece, or we studied this one kid and he had this one genetic mutation and this is what we found. That's nonsense. Like, you're going to make 9 billion people on Earth change what they do and how we think because of one kid with a weird genetic mutation? Like, that's just crazy. That would be malpractice at its worst.
I think another thing that's important to mention that maybe the general public doesn't realize is the scrutiny that goes into reviewing research before it actually gets published in peer-reviewed journals versus other kinds of publications that don't have that level of scrutiny.
That is definitely true. A lot of the better known journals will have a peer review. But a lot of nonsense studies get past peer review. And there's some of these journals that are weaker journals. Some of them, if you pay $1,300, they'll publish anything you send them. So like I'm a published author. You can almost publish anything if you pay some of these journals the $1,300 fee or whatever to make it accessible to everyone. And I think that's unethical. But if you really want to make a name for yourself and get your name out there, you can publish almost anything if you pay enough. And yeah, obviously most well-known journals, and in each field like endocrinology, lipidology, cardiology, whatever, there's certain journals that are like, the highest level of peer review, but there's always some nonsense that gets through. So I think it still depends on scientifically literate people to tell the truth or get the correct information out there so that the public knows.
Another thing that can be confusing for people is there are some things that are sort of not disputable anymore, like certain things that we are extremely confident are true. And then there is research into new things, right? There's emerging research. And so sometimes I think when we talk about studies, if you don't have the context because you don't work in the field, it's hard to differentiate what is something that is well established versus what is something that even experts don't necessarily agree on because we're still figuring it out, and how to tell the difference. And I think what's happening with this whole LDL discussion is we're re-examining something that is already something that we know is true and has been very well validated over decades, versus other topics in medicine that we still need to investigate more. We still need to learn. We still need to do more clinical studies. One of my questions for you is, how would you advise people when they're reading a topic in medicine, when they're learning about something, is there a way for them to evaluate if this is something that's tried and true, the jury's out, we know that this is, the causative mechanism for XYZ illness, or is this something that we still don't fully understand and there's maybe some differences of opinion, some flexibility and choice in how we manage this because we don't have good enough evidence to have a standard of care yet? That comes up a lot in my practice.
Yeah, so there are a lot of things, like you said, that are pretty well established in medicine. And then things on the fringes, we're still trying to figure out the nuance. A lot of people will write comments on some of my videos saying, well, the science changes every 5 minutes. Technically true. We learn new things every day. But there are some things that are well established that are really not debatable. Like high blood pressure causes strokes. High blood sugars is diabetes. It needs to be treated or needs to come down, whatever. There are certain things that are well established and we have very good evidence for. There are obviously some things on the fringes that we're still discovering, obviously, but it's not like it's a whole paradigm shift. Like very rarely do we have some new groundbreaking thing that flips everything upside down. And anybody who's telling you that is probably lying. Like, we're like, oh, this flips the cholesterol theory upside down. Like, no, probably doesn't. I mean, you would have to turn Earth into a square to make that happen. Like, there's just no way you can completely flip the cholesterol upside down. That just makes no sense. But there are studies that come out over time that add a little bit more to our knowledge base.
I think it's important that we touch a little bit on the press conference that just happened in the last week. And I want to be careful about how we discuss it. I want to talk about it in a way that doesn't alienate people of different political parties. I feel like this is something that's important for all people to understand the difference between something that's fully baked and ready to be brought to the public to potentially shift how we practice and change guidelines versus something that is still preliminary research, or we don't really have enough data that it would compel anyone to change how they practice. And again, it's a little difficult to navigate this conversation. The problem is with what happened during that press conference is that our government officials overstepped what they should have done. They crossed a line in terms of essentially stating something as fact that really wasn't fact.
So first of all, I agree with you. As science communicators, we need to be neutral in terms of politics because I don't really care who's doing it. What I care about is we're getting accurate information out there. I don't think you should trump out the president, pun intended, I guess, but you shouldn't put the president on stage to make a press conference about Tylenol. Who thought this was a good idea? You run the CDC now. You could have easily just published a simple little thing on your website saying, hey, caution Tylenol in pregnancy. No one would have cared, but you bring out the president of the United States and you put him on stage and he's reading some thing that they prepared for him, I don't know if the teleprompter was working or not, or whatever it was, did he practice it or not? Just not a good look. I mean, someone with more scientific knowledge should come out there, like the head of the CDC or the president of the American College of Obstetrics and Gynecology. They should be the one making this announcement or press conference. Like, if you're the president's handlers and you care about his public image and all that, like, why would you allow them to put him out there making a statement like this? And I get it, he kind of does these things on his own anyways, he might not be able to control it, which is fine, but I think that we need to be super careful. Like, the president's words should be, they should have some gravitas. Like, when you get out there to say something, it should be like important. Like, somebody's bombing the Philippines, like, this is important, everybody pay attention, we're going to do this. But like, to get out there and stumble on acetaminophen pronunciation and say something about some non-existent Tylenol dangers and all this, I don't think that's what the president of the United States should be doing. And the people in charge of helping him with publicity and marketing probably should not let him do that. Like, in a government like ours, where it's a representative democracy and all that, you're gonna have some ups and downs. I think we always seem to self-correct. And I used to work in politics. I mean, just so you know, like, for 4 years of my life, I was a speechwriter and a campaign manager for various presidential candidates, state candidates, and local candidates. So I think it's very important. And like I said, in our democracy and public opinion and like how things work, if the pendulum swings like too extreme one way, it kind of always comes back and settles in the middle. So I think, this too will pass. I think as scientific physicians and people, we need to do our best to just communicate the right information. And like with anything, people are either going to listen to us or not. I think people generally, the American public, is smart enough to figure out who really knows what they're talking about and who doesn't. I think the American people are smart people, and in general, we self-correct pretty good. It's kind of hard to break our system. There's been a lot of things that have happened in the past where you think it's absolutely going to break our system and the Constitution can't take this and all that, but I think it always seems to self-correct and come back in the middle.
Just reflecting on the press conference, if you try to give those particular government officials the benefit of the doubt, there is an argument to be had that their intention was to have a win in terms of making progress in research for autism. I mean, some of the announcements that they did make during the press conference were essentially announcing that there's going to be more money for autism research and things like that. And they were trying to give a platform to moms who have autistic kids who are struggling, how difficult that is of a journey for the moms and for the families and for the individual kids that are just having different kinds of challenges. And so I think that intention of giving a platform to people who are dealing with those kinds of issues, I think that is important. I think research for autism is important, and we definitely need that. If you put the president aside for just a minute and just think about, you had Dr. Oz on there, who's the head of CMS now. You had Dr. Makari, who's the head of the FDA, was on in that press conference. You had RFK Jr., of course, head of HHS. So you had all the people that are essentially in charge of our whole country's healthcare system at this point in time. So it wasn't just the president putting this message out there. He had an arsenal of people behind him that then spoke after he gave the initial announcement. And assuming that those people have some medical knowledge, right? Some of them are doctors, they're appointed to these high-level positions in our healthcare system. I'm assuming they had a deeper understanding of the articles that were cited than the president did. And they were heavily involved in directing this press conference and coming out with this information and the messaging and all of that. So putting the president aside for a minute and just talking about these officials that are more subject matter experts when it comes to healthcare in theory, their interpretation of the research is what concerns me, in the sense that I'm not sure. It was either a political stunt to try to get a quick win on autism and really knowing underneath of it all that it wasn't the win that they projected it to be, or they really just misunderstood the research. And I think it's important to talk about that, because not so much from the impact it has regarding politics or even this particular issue, but I think there's this kind of growing mistrust of science in our country and in our culture. And I think it comes from the fact that science is nuanced and difficult to understand. It's not like Newton's law, right? Where it's irrefutable all the time. Science is a messy process sometimes. There's, like you mentioned, tons of articles out there basically saying one point is true, and then a ton of articles that say that same point is false. And learning how to interpret and analyze research studies and how to put them in the context of what you want to actually bring into clinical practice is not an easy task for even physicians. And, like we talked about this earlier in our discussion, there are certain things like LDL particles lead to atherosclerosis, plaque formation, strokes, heart attacks. That's sort of like an irrefutable fact because we've had so much research over so many years that shows that over and over again. But then there are other topics that still we need to do more research to understand them. Autism is a perfect example. We don't really fully understand what causes autism. It's a fallacy that doctors know everything. We don't know everything. We are skilled at interpreting data and information. We memorize things that are facts, but we also interpret new data as it comes in, and we synthesize all of that to come up with our best recommendations that we can make based on the information that we have. But there's nothing that's 100% guaranteed is always going to work exactly the same way, because people are different, medications interact differently with different people's bodies. There's always different variables that are at play. And so I think it's important to say that just because science is messy doesn't mean science is wrong, but it's probably underestimated by the non-science community in terms of its level of complexity and the challenges in how you navigate new information that's coming forth and interpret the validity of studies when these are new ideas, new theories that we're developing and evolving versus things that are, pretty much settled. And so we shouldn't throw the baby out with the bathwater. Just because science sometimes fails us or doesn't always give us the right answers every single time doesn't mean it's all bad. It just means you have to understand it in the context of what you're looking at. And not all studies are created equal. Not all topics are fully understood at the same level, but that doesn't make science bad. I mean, science is the tool that got us to where we are today in modern medicine. Without it, we would have been lost. Without this process of how we evaluate theories and demonstrate if they're true, or we create a hypothesis, we demonstrate whether or not it's true, and then other people weigh in and they try to replicate it. I mean, without that messy process, which can be confusing.
Well, they try to prove you wrong even. I mean, the reason you have to publish your methods is because someone is going to want to try to prove you wrong. If I say I did a study and it showed XYZ, someone's going to be like, there's no way that's true. I'm going to prove them wrong. And they all want to outdo each other. So there's a lot of competition. When we say something is pretty settled in the science, it's because hundreds of thousands of studies have been done with millions of data points now, and people tried to disprove each other on this one topic and weren't able to. It's like if you go back, I always use this example. If you made it to 15 years old by 1890, half of all people that made it to 15 would be dead by 35 and the other half would live longer. So it's because of science and medicine and technology that we now live to almost 100. Like last week, I saw 10 patients. 2 of them were over 100 and the others were like well into their 90s. One of them was 91. But I mean, like, we're getting more and more people to have healthy lives. And I definitely think the future looks very, very bright for science and medicine, and it's only going to get better. We hope that the government and politicians and everyone will eventually continue supporting our efforts to prolonging life, helping people live healthier, happier, longer.
And I think also, if there's a moral of the story of what happened this week with that press conference that we can at least take away from it as a reminder is, I think when there is something that we really wish we had an answer for, there's maybe this desire to just jump on the first thing, right? Like to say, oh, look at this study and hold it up. But we have to caution ourselves against that and make sure that we really thoroughly vet where that research came from and how that study was designed. Because like you said, anyone can go online and can Google any number of studies that are going to prove any number of things, or at least say that they prove any number of things. But when you really dive down into it, the study design was flawed and it starts to fall apart. Although their authors are really want to try to convince you that what they found was the solution to everybody's problem, the reality is a lot of times the data just isn't quite there yet. But that's part of the process. That might be one study that leads to another, and then eventually we find our way. So it doesn't mean that study was even necessarily bad, but it's just kind of building the foundation of knowledge on a particular topic, and it takes time. It's very rare that we have like one study that just kind of comes out of the blue, like out of nowhere, and just solves some unsolved problem. That's not usually how it works. There's usually a lot of people studying something over a long period of time and contributing to that conversation with different research and different data outcomes. and arguing about it and convincing each other of what the right thing is before we actually find what the real cause is.
I totally agree. And a lot of studies, I mean, like you said, you got to know how to read them, but the confounders and covariates and some of these things are not always controlled. Definitely can make a huge difference. And if you've never been to a journal club, or you never presented, never did your own research, never worked on like a PhD, very difficult to learn as a layperson how to do any of this. So absolutely.
Yeah, I mean, I think we had one comment, somebody said something like, oh, well, Chat GPT is really great at telling me everything I need to know about a research study. I don't
I
think
mean,
we're
it's
there.
probably good preliminary info, but
Yeah.
it's definitely not capable of analyzing research. Let's put it that way.
Yeah, it might be good at summarizing the study, but it's not really good at weighing it in the context of the full body of research around that topic. That's the issue. And we don't look at studies in isolation. We look at them in the context of the body of research as a whole. So that's something that would be missing if you tried to like run a study through Chat GPT. And the confounders, that's another thing. You could have a study that looks beautiful, it has a great result at the end, and it looks like, there was an association between one thing and another thing, but then you're going to actually come to the wrong conclusion for the very simple reason that you didn't look at all of the variables that were contributing to that outcome. And that's the problem when you do an observational study, right? Because you're not controlling all of the different variables. You're studying something that's naturally happening, and you have your hypothesis and you're recording all the different variables that you think are contributing. But what if you missed a bunch of variables that you didn't account for?
Or like the study just doesn't add up. Like you did this whole study and something just doesn't sound right. And then you go back and reanalyze this one variable or their smoking history. Then you realize, oh, well, maybe it was this. You have to know enough to be able to even think of that stuff. But obviously, you gotta know how to do research, how to analyze it, and that's why I think we need experts. We need experts to speak up, because if you were to tell me, well, there's this one study that showed that low LDL kills you, like I would tell you immediately that's reverse causality. That there's no way that LDL being low actually contributes to your death. And actually, in every study that's been controlled and done properly, it actually prolongs life, reduces cardiovascular mortality, outcomes, everything. So that's not even a possible outcome of what you said. Sure, there might be a study that reported that as its outcome, but here's why.
It reminds me of something that my mentor from Mayo Clinic told me like 20 years ago when I was in medical school, and now he's in charge of research for all the different campuses of the Mayo Clinic. What he told me was, in order to be a researcher, you really have to have a good heart. You have to be ethical, because if you're so enamored with your hypothesis and you're so attached to it being correct, you can really massage the data and leave certain things out to get an outcome in your conclusion that supports what you want it to show. And so if you proceed with the study and you're starting to see some things don't add up, if you're not an ethical person, there's ways that you can massage that data set to then still produce something that is in line with what you originally hypothesized. And so you have to keep your ego in check, and also just kind of keep your own biases in check as you're conducting research, because the outcomes of those studies really ultimately at the end of the day do influence people's lives. If we get the answers wrong, it really messes things up for the medical field and for the world.
But in the example that you gave, this is why people have to publish their methods, because then I can say, well, what she published doesn't really add up. Let me repeat her study. So I take the methods and I redo it 10 times. Like, you know what? There's no way. How did she reach this conclusion? I repeated her exact study with the exact solutions that she used, the exact protocols. So then I would publish, my study saying, look, Dr. Joy was completely wrong, and here's why. Like scientists do that. Like, they're trying to one up each other, not in a malignant way, but in a way to prove like, hey, look, what you said is not right. And they want to win prizes and get, research grant dollars and all of that. So I think that's why it's important to publish methods and results and, be very meticulous, so that other people can try to replicate what you said and kind of like check each other, like checks and balances almost.
Even amongst experts, people that are trained to interpret science and research papers, we all have our different fields of expertise and our strengths. And so it's just unrealistic to expect somebody who doesn't have that deep expertise to really even be able to look at a study like what was presented in the press conference and to really truly understand what it means. It really takes
absolutely
consulting the experts in that field of autism, or people that look at the causes of autism.
and asking their opinion. Have the person who published the study come on to the podium and talk about their study. I think you would have gotten a really different perspective, because the researchers that published that systematic review that looked at all the studies from 1987 or whatever it was to 2024, even they didn't say never take Tylenol. They said use it when medically indicated. Basically, we don't have great alternatives. There are risks to not treating fever and pain in pregnant women. There are risks to the fetus. There are risks to the mother. It comes down to trying to restrain yourself from being enamored with finding the solution, because it's usually not as simple as we think. Unless we're experts in the field, we really understand how to interpret those results in the context of the knowledge that we have.
No, I totally agree.
Sometimes there are things that are newly discovered that it takes a long time to get widely accepted, right? Because we haven't done all the studies, or there isn't sometimes the financial backing to do the research that would be required to bring something to market. And yet, sometimes patients still may benefit from some of these emerging treatments or diagnostics or strategies that are right now maybe not standard of care, but could someday in the future become the standard of care, just like the GLP-1s discussion that we had earlier. As a primary care doctor and former emergency physician, I'm looking at all different kinds of disease states, all different kinds of specialties. I'm interacting, with the GI specialist, with neurology, with urology, with nephrology, with cardiology, So our scope is really broad and we see a lot of things. And there are certain conditions where we don't necessarily always have a great standard of care to offer the patient to solve the problem. And we're hopeful that at some point there will be more research that comes to bear and we will develop what is the standard of care for this thing. One great example that comes up a lot in my practice is irritable bowel syndrome. Okay, irritable bowel syndrome is sort of this umbrella diagnosis that we lump patients into when they have GI symptoms that we can't figure out what it's from, right? They don't have Crohn's disease, they don't have ulcerative colitis, they don't have a motility disorder. They've had a huge GI workup, they've had colonoscopy, endoscopy, biopsies, all of these things. They don't have celiac, they don't have food allergies, and they get lumped into this irritable bowel syndrome. And as a primary care doctor, I'm not the specialist, right? So I'm kind of the one that gets these patients back from all of these specialist consultations, and the specialist's like, it's not this, it's not that. And I'm left with the patient sitting across from me, and we're sitting there scratching our heads going, okay, what are we gonna do now? There are, not just in GI, but other disease states that we encounter a lot in primary care. Fibromyalgia is another one of them, right? Where we don't have a silver bullet solution. And my opinion is that it's probably because it's a syndrome rather than a specific pathology, and we don't understand it deeply enough to understand the root cause. How do you balance these kinds of issues with a lot of the trial and error things that we may want to offer the patient that may or may not work, but it's somebody who's left with no alternative? Versus in cardiology, we have ways to lower your LDL and prevent cardiovascular disease. We may not have an evidence-based, solid, tried and true, proven way to eliminate someone's irritable bowel symptoms. Does that make sense?
Yeah, so in cardiology, we have a very similar condition called POTS syndrome, or dysautonomia.
That's a great example. I'm so glad you brought that up.
Patients come to me from all over the world with this condition that could be almost anything. They come in, they're fatigued, they're tired, their heart races, they get dizzy, they get lightheaded, their pressure's always low, they have all kinds of symptoms, GI symptoms, head symptoms, musculoskeletal symptoms, like it's everything. We have a guy in Ohio, in our same city actually, that's a POTS researcher, and we share a lot of data and patients and whatnot together. And for someone who sees a lot of these patients, I agree with you that there's a lot of these things where modern medicine still hasn't figured out. And it's going to take studies and data and practice and experimentation. So there's going to be some of that. And like I said, on the fringes of medicine, but a lot of things we know what to do. And not everything's like, blood pressure, take XYZ, you're good. Some things are going to be like, we need to experiment and figure it out still. So I think there's definitely room for that. And I'm sure we'll figure some of these things out as time goes on.
So it can be really tricky. We have to weigh the cost and the risk associated with trying things versus the potential for benefit. And if the potential for benefit outweighs the risk or the cost, then maybe it makes sense to try. But if that's not the case, then we have to come up with a different strategy.
This is the part of medicine where patients teach you.
Yeah.
Like I know people are like, well, you're always just telling us what to do. Like, no, a lot of times you're telling me what to do. Like you're coming in, you're saying, doc, I tried this, I tried that, it didn't work. But the one time you gave me this one thing, It worked amazing. So we learn from patients as much as, I always tell people, when you're a doctor and in any field, whatever field you're in, you're going to be a student for the rest of your life and you're going to be a teacher for the rest of your life. You're going to be teaching your patient, your staff, and then you're going to be learning from everyone around you because it's a field that's always evolving and you should be learning all the time.
If you could change anything in our healthcare system, what would it be? I know that's a loaded question.
So many things.
And there's so many things, right? But what would you pick if you had to pick
So
one?
if I had the answer, I would probably be like running the administration or something. But I think the third-party payer system where the patients are not my patients. The patients actually belong to a third-party payer insurance company, and they're the ones paying the hospital or me indirectly. You have a corporation paying you to take care of patients instead of you sort of directly taking care of patients. I think that's a huge problem, but I don't know that there's a way to get rid of that now because it's kind of like ingrained. Should the government pay for everybody's health insurance like most countries in the world? Maybe a little bit, and then you can buy extra insurance on top of it. I really don't know. And I'm sure there's very smart people working on this, don't get me wrong, but the problem is there's always financial incentives to not fix it. Sometimes it's hard to break that because the money going back and forth is not in our interest to fix it.
Yeah, it's so entrenched.
Yeah, it's entrenched and people make so much money keeping it at the same. And it takes away the patient-doctor relationship because I'm no longer I'm talking to my patients, but literally Blue Cross is who's going to pay me for it. It's just weird.
It's like Blue Cross is sitting there in that conversation with you sometimes.
Yeah.
We're sitting on your shoulder, and I understand what you're saying, and I think all of us physicians do our best to ignore the insurance companies sitting on your shoulder, but we do have to play by their rules to get things paid for, or nothing will get done.
The problem is getting medications approved. If you need to be on Ozempic or inclisiran or whatever, we have to argue with your insurance as to why you need to be on it. It puts a barrier between the patient and the physician where I have to justify my medical decisions to a random person sitting in an office making decisions. So it's kind of weird. That's the one thing we definitely need to fix. I don't know what the answer is, but that's the one thing that really needs to be fixed.
So despite all of the problems in the healthcare system, what keeps you inspired?
I'm inspired by the stories people tell me. Every day somebody puts a comment saying, you know what, doc, because of you, my LDL is 30 now. Because of you, I'm no longer scared to say this to my doctor. As a physician, I could see 20 to maybe 100 patients a day in person. But online, like I said, 8.9 million people see my videos or texts or whatever I post every month. It makes you feel like what you're doing is making a difference and having a real impact. I hope I'm pushing the debate or conversation forward and getting people to ask the right questions, inquire about the right things, motivated to work out. You don't want to just sit at home and take rosuvastatin but eat butter wrapped bacon every day. Makes no sense. So I hope that motivates people at least to start the correct conversations, ask the right questions, go to their doctors, get motivated to work out. That's my goal, and that's my inspiration.
Thank you for listening to Your Doctor Wants to Quit. I'm Dr. Joy, a board-certified emergency physician, and I created this podcast because I'm on a quest to fix healthcare through conversation. If you liked what you heard today, please follow this podcast and share it with your family, friends, and colleagues. By spreading awareness, we can bring about change. You can also connect with me on Instagram at drjoymd. That's DOCTOR Joy MD.